A mass exit at CDC and a new confusing label for COVID-19 vaccines from the FDA. This is America Dissected. I'm your host, Dr. Abdul and Katelyn. So Katelyn and I initially recorded an episode on Tuesday, but given that there's been a lot of changes over the last week, I wanted to come back through and re-record. So this is an update as of Wednesday, August 27th at 8:30 p.m. Eastern Time. So the first most important piece of news here is a huge shakeup at the CDC. Susan Monarez, who had just been approved and confirmed by the Senate just a couple of weeks ago, she's out. She resigned. And the announcement is kind of confusing. It reads, quote, Susan Monarez is no longer director of the Centers for Disease Control and Prevention. We thank her for her dedicated service to the American people. So, of course, this is really confusing because a Senate confirmation is no easy task, and you don't do all this work of getting somebody confirmed by the U.S. Senate to oust them just a few weeks later. So what really happened here? Did Monarez decide to leave given all this news from the FDA about the COVID vaccine that's coming soon? Was she pushed out? It's really unclear. But what we do know is that she was walking a really difficult tightrope. On the one hand, she's somebody who's been at the CDC in the past and seems to have a strong fealty both to the institution itself and the science that motivates its work. And at the same time, she's operating under the leadership of RFK Jr. And if you listen to this podcast, I don't have to tell you too much more about that. But that put her between a rock and a hard place. So it's not that surprising that, unfortunately, this is the outcome. What do I think about it? Well, Monarez might have been the steadiest hand we could have expected to operate under RFK Jr. And I worry about what this means for the next appointment. Remember, she was the second name floated. The first was a former Congressman, David Weldon, whose nomination was pulled before Senate confirmation. And she's not the only one who's out at the CDC. You also had three other high-profile folks resign. First, the chief medical officer. Second, the director of the National Center for Emerging and Zoonotic Infectious Diseases. And third, the director of the National Center for Immunization and Respiratory Disease. I want to read for you an excerpt from one of those letters. They wrote, quote, I am not able to serve in this role any longer because of the ongoing weaponization of public health. Another wrote, and I quote, the ongoing changes prevent me from continuing in my job as a leader of the agency, and added that science should, quote, never be censored or subject to political interpretations. You can imagine that this is extremely destabilizing, given that just a couple of weeks ago, you had an individual who shot hundreds of bullets into the windows of the CDC, and a brave law enforcement officer who tried to stop him lost his life in the process. The question now is, what next? Who's going to lead the CDC? I worry that the next choice is going to be someone who's much more of a sycophant, somebody who's handpicked by RFK Jr. to just give a rubber stamp to the things that he wants to do through the CDC. And that's going to be bad for all of us. The other important piece of news to discuss, since Katelyn and I first taped, is the release of the FDA's licenses for COVID vaccines. They approved the next COVID vaccine for the fall season, sure. The previous vaccine was licensed for everybody aged 6 months or above, meaning that anybody over 6 months was included under the FDA's label. The new license, though, given this year, is only for people over 65 and people with underlying medical conditions. So that's a big change on its own terms. This means that if you don't belong to any of these groups, by definition, you'd have to be taking the vaccine off-label. We're talking about literally everybody who doesn't meet certain health criteria under the age of 65. But FDA and CDC might not have the last word. Last week, following recommendations from the Vaccine Integrity Project, whose leadership we interviewed, Dr. Mike Osterholm, in the last episode, we saw movement from the American Academy of Pediatrics and the American College of Obstetrics and Gynecologists. They were getting ahead of today's announcement, recommending that all children under 2 and those with high risk and those living with somebody at high risk get vaccinated. And the American College of Obstetrics and Gynecologists recommends pregnant women receive the vaccine at any point during pregnancy when planning to become pregnant or in the postpartum period or while lactating. So you can imagine that this sets up a very clear inconsistency in terms of who's recommended to take this vaccine per the federal government versus those who are actually following the recommended science. The race is on, though, for who insurers and the broader medical community will trust. Ultimately, it creates chaos in terms of the recommendations that people ought to use, particularly for parents and those who are pregnant. There are also a couple of important questions that sit between these two stories. Were these departures from the CDC coincidental, or were they driven by decisions with respect to the COVID vaccine? And I think more will come out over the next couple of weeks on that. And then take it a step further. You've got the Vaccine Integrity Project recommendations, and you've got the official FDA and CDC recommendations. Do departures at the CDC bolster the Vaccine Integrity Project recommendations? And how will the public interpret that? And then, of course, there's the decision-making of the medical community itself. Do physicians decide to recommend and prescribe COVID vaccines off-label? Is there a liability that they both hold? That's not likely to be true, given that physicians can recommend medications off-label, and they do it all the time. But what are the implications? Is RFK Jr. going to try and hold physicians and other medical professionals accountable to these recommendations? And then, is this even the last word on COVID vaccines? And to that end, we're going to have to wait and see. So Katelyn just released recommendations for parents and adults that I think are worth thinking through. The first is, I would recommend talking to your kids' physicians regarding what their recommendations are, particularly considering the American Academy of Pediatrics recommendations. If you're an adult and want to protect yourself, even if you don't fall into one of these groups, meaning if you're over the age of 65 or have certain medical conditions, I would talk to your physician and ask them whether or not a COVID vaccine might still be right for you. And then lastly, let's not forget, given these different recommendations, insurance companies may not be required to actually cover your vaccine. So it's worth having a conversation with your insurance company before you get that vaccine, or identify alternative ways to make sure that you can afford it. That's a crazy thing to have to consider. Then let's step back for a second. All of it, portends to a certain kind of chaos. This administration appointed somebody who had a predisposed ideological approach to vaccines. That person has now tried to inflict their personal perspective, one that they've clearly spent a lot of time making a bit of money on, into our federal government's recommendations. And that means millions and millions of people are now having to decide between an alternative recommendation, one based on science, and one based on the preconceived ideals of the person running HHS. And the reality when it comes to vaccines is that the easiest thing to do is nothing at all. And you wonder how many people are going to go without a vaccine that they otherwise might have or should have taken, and how many of them are going to get sick and potentially die because of it. And that, of course, is the broader consequence here. On this show, we try to bring you up-to-date, real-time information about the public's health and the ways in which society and science interact to create it. And this is one of those examples when we fail to put science at the very heart of decision-making, and too often, folks unwittingly suffer the consequences of it. So we'll be watching as the story continues to unfold, and now we'll move on to the rest of the show.
Okay, let's pivot on an update of NIH research grants. So in the past 6 months, Trump administration has canceled $2 billion in NIH research grants. And this has really prompted a string of legal challenges in the federal court that have been a little hard to follow. But last Friday, we got a major setback. Abdul, can you explain?
Yeah, basically the Supreme Court said that in Donald Trump's jihad against the DEI, that he could sweep up NIH grants too, right? So this was one of the first major cases finally reaching the Supreme Court on this question. The case represented 1,700 research studies totaling $800 million in research grants. So if you think about it, that's nearly half of the grant money in question. And the Supreme Court ruled on Friday that Trump was within his authority to cancel those grants, which all had some connection to DEI. This is, of course, a major setback because it demonstrates the ways in which this administration has gotten basically carte blanche from the courts. Katelyn, the justices added a sliver of hope in one part of the ruling. Can you explain?
Yeah, so SCOTUS ruled that the legal disputes around this over the federal grant should be filed in a different court system, the Court of Federal Claims. And so they basically told the plaintiffs, take your case there. So it means the Trump administration can withhold the grant funding for now, but if a Court of Federal Claims rules in the plaintiff's favor, the money could be restored later. Bottom line, there's going to be just a long string of legal actions and no idea how long it could take. And even if they will prevail, how much this lags on research and time and effort, and the community is already being left behind. I mean, these were grants already signed contracts with communities to measure and improve health. And so it's not great that it's delayed, and researchers are incredibly frustrated of the constant whiplash. And I think it is still a major loss to public health, right? These grants were addressed to well-documented health inequities, and plain and simple, it widens existing gaps in outcomes as well as access.
Yeah, I want folks to understand, like, imagine you go to work every day and you're like, okay, I have a job to do. I am asking a really big research question and I've got an 18-month to 24-month project. And then all of a sudden the money's gone and then it's back and then it's gone. And all the while you're managing relationships with hundreds, if not possibly thousands of people with whom you've made a connection and you've committed to doing a certain set of things. Like, I just want folks to understand that, like, even if it's reinstated, these pauses, they've set back the research enterprise dramatically. I mean, a lot of the study criteria that we build, right, you're comparing things across time. So you can't just stop collecting the data that you have because it ruins the time horizon and the study design itself. So this is just, I mean, it's just a devastating thing. And one of the most incredible things our government does is collects data on our country. And I just want folks to understand that, like, when you start going after data collection or science, you are actively going after truth, right? And that's, those two themes keep coming back up: truth and control. And the thing about truth is you can't control it because it's just either true or it's not. And so I want folks to understand this within broader context because it helps us to understand where they're headed next and the reasons for which they're behaving this way. All right, Katelyn, we have some some other interesting stories. We wanted to discuss the radioactive shrimp situation, which gives a whole new meaning to bang bang shrimp. But I've been holding on that one for a long time. It's my dad joke of the day. Sorry.
It's funny. It's funny, Abdul.
All right. We've also got flesh-eating maggots that fly, and we debated about which one to tell you about. So here we're just going to give you information about both. So what we're talking about here is raw frozen shrimp sold at major grocery stores all over the United States. They're recalled because inspectors found trace levels of cesium-137 in the shrimp themselves and the shipping containers that transported them. Cesium-137 is a radioactive isotope left over after nuclear reactions. If you ingest it, well, it can, of course, do what all radioactive materials can do. So just a quick primer on radioactivity. So remember, an atom is a nucleus, and the nucleus has protons and neutrons, and then you have electrons, which are like these tiny little things that flow around the nucleus. When we talk about radioactive material, we're talking about unstable nuclei. And then what happens is parts of those nuclei blast out of the atom. And when they blast out, right, they can go and they can cut stuff that they blast through. And in this situation, the reason we're so worried about them is because one of the things they blast through is DNA. And if they blast through the wrong parts of DNA, they can stop your body from doing certain things that it needs to do. And one of those things is a signal that your body gives to cells to stop replicating. And that's basically what cancer is, right? Cancer is what happens when a cell decides to start replicating over and over and over again. And so when you have exposure to radioactive materials, it's that splitting apart of atoms that rips through DNA that allows some of these regulatory parts of DNA to stop working, that then increases the probability of cancer. So cesium-137, bad. Radioactive shrimp, also bad. Well, the question then becomes, like, is this something we should be thinking about? Katelyn, what do you think? I mean, like, I ran 2 health departments. Radioactivity is not something we usually test for. You can imagine them with a Geiger counter on the food.
I mean, yeah. So this comes down to how we get our food and where our food comes from. Apparently, the majority of shrimp, what is it, like 90% of shrimp, come from overseas. And so there is a lot of actually testing done at ports. And I'm glad that this was caught. I want everyone to realize, though, that the risk is low. It's not like we're going to be all glowing because we're eating shrimp everywhere. I mean, the primary health risk is through long-term repeated exposure, and which leads to cancer. And what the levels detected are below levels of concern for imported foods, but it's just best to toss the shrimp out. And I think we really need to think through whether dismantling, I don't know, FDA inspectors across the nation is what we want to be doing right now. It's just another example of why the government does this, to ensure that our food supply is safe.
Yeah. Katelyn, it's funny because, like, one of the subtexts of everything Maha is that you need to be the arbiter of your own health, and the government just needs to get out of the way. And the problem is that government does a lot of things in the background you don't even think to do. So, like, in this new Maha world, you're not ready to think through all of the potential risks, nor should you have to.
I was just saying,
And
I don't want to. Like, I have 2 kids. I'm like barely alive, right? Like, no. It's supposed to be there to make our life easier and safer and healthier.
All right. Well, on that note, let's move on to the other story, the flying flesh-eating maggots. Katelyn, care to explain?
Yeah, so this is called the New World screwworm. It is a parasitic fly. It was actually used to be in the US decades ago, but we eradicated it. And what happens is the flies burrow into the wounds of animals, and it just can devastate livestock. There was back, I think it was in like the 70s or 80s. I mean, there were millions of cattle that died from this parasite. This parasitic fly is endemic in Central America, but it's now creeping up north. It's about 350 miles from our border. So it's going to hit Texas probably first, and then California. Could have cost billions of and drive up meat and dairy prices. There's two things I think about this. One is the good news is we have a fascinating and very effective strategy that USDA could deploy, and they're actually thinking about deploying it in Texas for a preparedness. Is they release hundreds of thousands of sterilized male flies, which mate but then don't produce offspring, and it can crash the local screwworm populations, which is just so cool. Science is so cool.
I feel like they give a new meaning to the word screwworm. There's like F-worm problems.
Foreign problems. That's good. Another dad joke. That's good. But because we're seeing more and more of this, we'll probably see more human cases. And actually, human cases are really rare, right? The most devastating is livestock. But there was just a recent traveler in Maryland who returned from a trip with an infection acquired abroad. And it can be treatable, which is also great news. Very painful. They have to like surgically remove the larva from your wounds, which sounds terrible. And but treatable, and it's not like this can spark a pandemic outbreak. The odds of this case sparking one is essentially zero. But so for now, it's very much a watch and prepare situation. I'll be curious to see what USDA does next.
Well, I'm grateful for the sterilized flies, and also mark this under new problems that we didn't know we had to deal with. Thank you, Public Health, for dealing with them.
It's on our bingo card.
Yeah.
Cross that off our bingo card.
Wild. Yeah, exactly. Way to make America healthy again.
Yeah. Abdul, who'd you talk to this week?
I had a great conversation with Dr. Taylor Walker. As you all know, we're approaching Labor Day weekend, so we are going to be off next week. But we had an amazing conversation. She is the president of the SEIU's Committee on Interns and Residents. They've been organizing the nation's largest doctors union, and mainly focused on early career doctors, the folks who do the really, really hard work in early in their training in our nation's hospitals and clinics. And given the state of healthcare right now, the CIR has had a surge in interest, which is a really good thing. We had a great conversation about corporatization in medicine, why it's so important for doctors to come together in unions, and the fight for a fair, more equitable healthcare system for the future. So I hope folks will stick around. And to everybody, I hope you all have a fantastic Labor Day weekend. Again, we're going to be dark next week, given the holiday, but we'll see you the week after that. See you, Katelyn.
Bye.
America Dissected is brought to you by Incogni. We live in a world where personal information is more accessible than ever, sometimes a little bit too accessible. Data brokers collect and sell your private details, your name, home address, phone number, even your browsing habits, without you ever knowing. That's why I'm partnering with Incogni. It's helped me take control of my online privacy by removing my data from shady people, search sites, broker databases, etc. It hunts down these unethical sites and gets your info removed from the places that expose your private information. Incogni automatically and continually monitors your data privacy without you ever having to lift a finger. All you need to do is grant Incogni permission to make requests on your behalf, and it'll contact all these shady sites requesting the removal of all your personal information. Its professionals will handle any objections and keep checking back in to ensure your information stays off these sites. Given what I'm doing right now, you can imagine the online trolls trying to scour the internet for my personal information. So keeping my and my loved ones' personal information off the web, it's a must. But with Incogni, I can rest assured that I've got the best in the business watching out for me and my family. And now they've introduced something huge, custom data removals. With their unlimited plan, you can copy and paste any link where your info shows up on sites beyond their usual list, and their privacy team will work to get it taken down. Incogni's private experts actually go in and handle the removal manually, even from sites that are harder to deal with. It's like having a privacy SWAT team on speed dial. Right now, you can get 60% off their annual plans by heading to incogni.com/dissected. That's using the code DISSECTED at checkout. It's also completely risk-free. Incogni offers a 30-day money-back guarantee if you're not satisfied with them removing your personal information off the internet. Live free from dangerous spam by using Incogni. That's incogni.com/DISSECTED, Dissected, for 60% off their annual plans. All right, can you introduce yourself for the tape?
Yeah, absolutely. My name is Dr. Taylor Walker. I'm a board certified family medicine physician. I'm also the national president of CIR SEIU, which is the nation's largest labor union of physicians. We represent 40,000 residents and fellows across the United States. And I am based in Washington, D.C. I'm here on the podcast because I fundamentally believe that physicians and all healthcare workers need to think of themselves. We need to think of ourselves as organizers. We need to think of ourselves as part of the larger labor movement so that we can stand in solidarity with the rest of the labor movement in our fight for justice and a more equitable system that really prioritizes and protects the health and wellness of all U.S. citizens.
Well, I appreciate that, and thank you for joining us. And we're grateful to talk to you right here around Labor Day. You've talked about your work, and I want to step back because I don't think a lot of folks, unless they're in medicine, don't necessarily know what residents and fellows do. Can you tell us a little bit about the day-to-day of a resident and fellow and what kind of work it is?
Yeah, totally. So the joke that I say all the time is like, oh, you've seen Grey's Anatomy? Yeah, it's not anything like that. But I think that's sort of the framework or the idea that people have in their heads about what a resident or what residency is. And things do get crazy, right? Like they do on Grey's Anatomy. But essentially, the reality is that we graduate from medical school as a doctor, as an MD, as a DO, and then we go into residency into our specialty of choice. So for me, I graduated from medical school and did residency in family medicine. You could do general surgery, internal medicine, whatever. And for a period of 3 to 7 years, depending on what specialty you choose, you are really the front lines of patient care in terms of the physician workforce. And so residents and fellows are working an average of 80 hours per week. That's averaged over 4 weeks. So realistically, you could work 120 hours one week, 60 hours the next, 80 the next, 100 the next, and that would be totally fine, right? That's 24/7, 365 days a year. Our schedules are made a year in advance. We always work holidays. We have very little control over our working conditions, over our schedules, over salaries, right? And we are really, like I said, the front lines of patient care. So if you have been admitted to the hospital, say, especially at an academic, hospital, like the bigger hospitals you've heard of, the first doctor that you see is almost certainly a resident or a fellow. And I think COVID, which I think we'll probably talk about a lot today, really shone a spotlight on the negative, sometimes dangerous, impacts that being that frontline worker can have, right, on these young doctors at the beginning, of our careers.
Mm-hmm. And one of the points that you often make is that too often physicians don't see themselves as traditional labor, and that it's critical for them to understand their role in this particular system.
Mm-hmm.
Why do you think it's been so hard for doctors to self-identify as labor?
Yeah, I mean, for one, the landscape of medicine has just drastically changed in our lifetimes. I think just one generation of doctors before me has a totally different concept of what it means to be a doctor. Because back in the 70s, 80s, 90s, private practices, physician group practices were huge. You had the opportunity to start a practice and build a practice with people who you enjoyed working with and who were values aligned, right? And you had a lot of autonomy to take care of your patients in the way that you're trained to take care of them, in a way that is consistent with your values, right? And we have seen this enormous, um, just huge expansion of corporatization of healthcare and privatization of healthcare. And I think, your work in this area is really what it has been hugely inspiring for me, and kind of got me into the whole into advocating for Medicare for all, because with this corporatization and privatization of healthcare comes more and more restrictions, less and less autonomy in terms of our ability as doctors to take care of our patients in a way that's values aligned and aligned with our training, right? And instead, we are forced to function in a system that consistently prioritizes profits over patients. And that is, I don't know, I have mixed feelings about the phrase moral injury, but like it causes a huge amount of moral injury for physicians working in this system today. And so I guess to kind of bring that back to the question of, okay, why labor? Like, why do we have to see ourselves as labor? The fact of the matter is that, at this point, 75%, 74% of physicians in the United States are employees of a large company, a corporation or a for-profit company, and therefore we are laborers. We are very highly educated, very highly skilled members of the labor force. And with that has come really a degradation of the autonomy that we have to take care of our patients. And so I think at this point, physicians have to think of themselves as laborers, as part of the broader labor movement. One, because we just are, and we have to accept that. And two, because the larger labor movement in the United States has always been the tool to protect middle class, to protect working conditions, right? To fight for justice and equity. And at the end of the day, that's what we as physicians are doing. We are fighting for justice, for equity, and for wellness for our patients. But we also need to do that for ourselves.
Yeah.
And I don't know if you've heard this statistic, but it's something that has stuck with me for a really long time. And it's that doctors can treat roughly 15% of the things that bring someone into the clinic, right? So as a family medicine doctor who has always worked in the safety net, right? I'm often the first doctor that someone has seen in a really long time. And I end up talking about housing conditions, lack of transportation, right? Needing work accommodations. And I say all the time, if my patients could just see a social worker before me, they wouldn't even need to see me. If I could just prescribe somebody a house, that'd be it. And, I can treat that 15%, but the rest of the labor movement can really, really help to address the rest of that 85%.
Yeah. And to your point, I think it's important for folks to understand that in the past, most physicians worked for a physician-owned practice. And usually what would happen is you would buy into the practice. You would work for a certain period of time employed by the practice, and then you would become a partner of the practice, much more similar to law firms. And then once you were a partner, you were a part owner of the company that you worked for. Today, that's not the case. Like, we've had a McKinsey-fication of the healthcare system in a way that allows the corporate side of it, whether it's corporate hospitals that are buying each other up in ways that suppress worker power, or it's corporate insurance that is cutting sweetheart deals to collude with the hospitals. All of that has made it so that the vast majority of physicians no longer work for a physician-owned practice. And so instead of being management, doctors are now labor. And I think the hard part about it is also that, doctors all where they saw themselves as special snowflakes. They got the best grades and jumped through all the hoops. And I think that gets played against them. So
Mm-hmm.
I want to ask you, in the work that you do, physician organizing, there's this drop off between organizing residents and fellows to organizing attendings,
Mm-hmm.
right? And can you speak to a little bit about why you think that drop off exists and whether or not there's opportunity to potentially get folks who've joined resident unions to see themselves as labor past the time in which they're in the residency or fellowship?
Mm-hmm. Yeah, absolutely. So, I have sort of begrudgingly joined the world of TikTok and social media because it's just simply how you reach the younger generation. Like, if I'm going to sit here and say physicians have to be organizers and we have to be laborers and we have to be politically involved in order to really take care of our patients and communities, like, regardless of how I feel about it, part of that is on social media, right? A big part of that's on social media these days. And so there's this thing going around on social media, basic on sort of medicine TikTok, asking, like, are residents a vulnerable population, right? And there's a discourse about that, whatever. You can tell my TikTok algorithm is exceptionally specific these days. So there's this question of, like, are residents a vulnerable population? And my answer to that would be absolutely yes, because residents do not have control over their working conditions, over their salary, over their schedules, over whether they're sleeping during the daytime or the nighttime, whatever. And we're the frontline workers, right? Like I've said. And so, it is absolutely imperative for any worker in a vulnerable population or any member of a vulnerable population to find ways to advocate for themselves and to advocate for protections and just basic protections, right? And so I think that is really the driving force for residents being the first wave of physicians to unionize. But, really just given everything that we've talked about, right? The erosion of physician-owned practices and this huge uptick in corporate and private companies buying medical practices and hospitals, attendings are increasingly finding, I'll say ourselves, because I'm an attending now, we are increasingly finding ourselves in this very similar position. And I think that there's this message that we're fed throughout medical training that, like, just get to the next step, it gets better, right? It does get better, but, like, it's a really different thing than
It still kind of sucks.
It still kind of sucks. It still kind of sucks.
That's the hard part about it, right? It's like, I think in the past it got way better, and it's interesting, right? Because there's this discourse between generations of doctors. Like I remember being lectured at by this very well-meaning attending who was like, well, she trained in the 80s. She's like, you med students these days, and this would have been 2010s. You med students these days want to have it easy, right? We used to stay back and just take care of our patients and do whatever our patients needed because, that's what our job is. And you talk to some, older school docs, particularly surgeons, and, like, that's the ethos, right? Yeah. And so they worked 80 hours a week forever and ever. The difference, though, is that they had a piece of what they built versus you work 80 hours a week for a large corporation who could cut you because you have zero job security. Right. And, physician wages, not to say that physician wages are all anything low. There's nothing to complain about there, but they've been suppressed. And more and more of the value that's created of a larger and larger pie is going to huge corporations that get to control and dictate what gets done. And it's funny because, I had sort of just been working on a project at that point. And I asked, I was like, you must have been a med student in the early 80s. She was like, yes. I was like, do you know how many medications were on the formulary in the early 80s? She was
I
like,
actually don't know
no.
the answer to that.
I was like, about 800. Do you know how many are on the formulary now? She was like, no. I was like, 10,000.
The limit does not exist.
Yeah. We have more than 10x the complexity of what we do.
Absolutely.
Right. And you had days and days with your patients because they used to be admitted, like the average admission time was like a week at least. Right.
Yeah.
And now they're in and out. So it's interesting because you have this sort of rose-colored glasses about the good old days. And I'm like, well, the good news is our patients actually leave.
Right.
right?
Yeah.
In your day, yeah, you killed a lot more patients than we did. That's a good
Hmm.
thing, right?
Hmm.
But it's a different practice, and the same cultural norms can't apply. It's like the same
Right.
thing as like getting lectured at by folks who went to med school in the time when most of their education was subsidized by a government in
Right.
ways they didn't realize about why we're complaining about student loans. You know what I mean?
Right.
It's just like, well, as a generation, our community has taken huge amounts of loans to be here,
Yeah.
right? In
Yeah.
ways that, that's the difference between ever buying a house and potentially not buying a house until you turn 50 on a physician salary, right?
Right. Hmm.
So like all that is to say, like there's just this cultural difference. And
Yeah.
it is a difficult thing in medicine because it's almost like you are taught to wear that work ethic on your sleeve,
Yeah.
right? And anytime you complain about doing a 24-hour, somebody's like, well, I used to do 2 36 hours a week. So, and you're
And you're
like,
like,
yeah, but like that was probably shitty and you probably killed a lot of patients doing that. Like
right.
that wasn't a good thing, right?
Right. Like,
Um,
yeah, how'd your patients do? Also,
yeah,
like,
like,
how's your family? Right. Like, and it, yeah, I think it's also, I'm sort of like laughing because I'm in $440,000 of student loan debt.
geez,
And I went to a public medical school, you know, and I went without health insurance throughout my MD and PH, my 5 years in my dual degree program, because Tennessee didn't expand to Medicaid. And I went back to medical school and I was 26. I had the audacity of going back when I was 26. And I very realistically may never buy a house or be able to buy a house, right? I'm so fortunate to have a partner who did, right? Um, but left to my own devices, like that's just not in the cards for me. And so you talk to this older generation, um, of physicians, and it's like, yeah, med school didn't cost the same as it does for us. You didn't graduate with $300,000 of student loans. Also, like your housing costs were nothing compared to ours. I took out a personal loan my third year of residency just to be able to pay my rent because I did residency in Boston. And the cheapest apartment that I could find was like $3,200 a month, right? And that is completely different. And also it's way easier to like afford housing when you literally live in the hospital because you know that that's where the term
that's where the
resident came
resident comes from.
from, right? Like this is truly 1.5 generations of physicians ago. Like we were called residents because we were residents of the hospital. Like you live in the hospital. Like, I mean, one, that sounds terrible, but two, that's way cheaper, right? And so it is, I think, important for attending physicians to like find it in themselves to check the validity of their own perception, right? Like your perception of being a doctor is very, very different than the reality that the younger generation of doctors is facing. It is a totally different universe, right? I think the other piece of it, the other perception that really all of us in the professional managerial class like need to check is that like we need to sort of check our privilege and like check ourselves when it comes to how we think about the labor movement, right? Like when people think about the labor movement, they're like, oh, steel workers and electricians and, nurses maybe, but like not doctors, not engineers, not lawyers, right? And and actually I'll tell you a story that I'm I'm not super proud of, but I think is really important to know. So CIR, my union, the Committee of Interns and Residents, is called that. We are called the Committee of Interns and Residents because in 1957, when we were founded, the founding group of doctors didn't want to have numbers in the name. So you can think of like 1199 as a huge healthcare
Hmm.
union, right? When you think about like union names, you may hear like local blah 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 followed by some numbers. the founding members of CIR did not want numbers in the name because they didn't want to be associated with those people, right? Like they didn't want, I guess, put another way, like they didn't want their union name to sound too much like a union. And I think that highlights a really fundamental problem that is the result of our own biases and perception that is actually damaging not just to ourselves and to our practice and our ability to like actually drive change, right? And build power and drive change in the face of these attacks on science and truth and innovation and whatever. But also like to take care of our communities, because our perception of like not wanting to be associated with the rest of the labor movement just undermines our own power, right?
Well, I think it's also just, I mean, you know, there is a class struggle, and I think a lot of folks perceive their quote unquote success at becoming a physician as being something that elevates them above other working people. And
Right.
that itself is dangerous to your point around the capacity for solidarity, but it is indicative of a deeper willingness to assent to an idea that somehow the labor you do is so much more important than the labor everybody else does, which is funny because in medicine, every doctor deep down inside knows that nothing you do is possible without the incredible nurses and the techs and the folks who clean the hospital.
Mm-hmm.
And so you are one cog, and albeit very important cog, in a system that is part of doing the same work. So, you know, if you're out there saving lives, then so by definition is the janitor who made sure that your patient didn't get MRSA in the room because they cleaned it very well, right? And I think it is that part of it that is a problem. And also, like, it is just, to your point, I think a lot of that is falling because of just how inequitable our society has become now.
Yeah.
In the sense that I think the real divide is like, do you have to go to work tomorrow or do you not?
Right.
And if you have to go to work tomorrow, whether you're showing up in your scrubs to round in the morning, or you're showing up as a tech, or you're showing up to clean the rooms at the end of the night, like you still got to go to work tomorrow. And
are you paid for your labor? Yes or no?
Right. Exactly.
Are you paid in dividends, or are you paid for your labor?
And is the company that you work for incentivized to figure out how to get you to do more and pay you less?
Yeah.
Right. And that exactly is true. And it's been very true for clinicians for a very long time. Y'all see this beautiful face? Well, that's because America Dissected is brought to you by OneSkin. In a recent episode we did on skincare, we learned that regular sunscreen is the #1 most important thing we can do to protect our skin, which is why I apply sunscreen twice a day. And my go-to product is OneSkin's OS1 tinted sunscreen. I wash my face, pat dry, and apply. It goes on smooth and feels natural on my skin. No splotchy spots, no oily feel. I also love the fact that it's free from over 1,500 chemicals and preservatives that can make skin red, irritated, or itchy. Their products are certified safe for sensitive skin, dermatologist tested, and approved by independent testing platforms like SkinSafe. They're founded and led by an all-woman team of skin longevity scientists. OneSkin's products are backed by extensive lab and clinical data to validate their efficacy and safety on all skin types. The reviews speak for themselves. They've got over 6,300 5-star reviews for their full line of face, body, sun, and travel-sized products. OneSkin's multi-purpose products prove you don't need a complicated routine to achieve healthier skin. OneSkin is the world's first skin longevity company. By focusing on the cellular aspects of aging, OneSkin keeps your skin looking and acting younger for longer. For a limited time, you can try OneSkin with 15% off using code Dissected, DISSECTED, at oneskin.co. That's 15% off oneskin.co with code Dissected. After your purchase, they'll ask where you heard about them. Please support the show and tell them we sent you. Give your skin the scientifically supported gentle care it deserves with OneSkin. I want to ask you, because I think you know, part of the reason you're passionate about this work, and I really appreciate what you do, and I think increasingly folks who are joining into physician unions are so passionate about it, is because we've watched our healthcare system get absolutely destroyed at the edge of corporate power.
Mm-hmm.
And one of the biggest voices against stopping that has been healthcare unions, whether it's
Yeah.
nurses unions or, the broader SEIU movement, who organizes a lot of hospital and healthcare workers.
Yep.
And I think we've been slow to the game. And I think we've been slow to the game because we have, to your point, resisted the willingness to show solidarity with our working sisters and brothers. And
Mm-hmm.
also we've been slow to the game because too often the same corporations can incentivize us, right, in ways that keep us on the wrong side of the conversation, even as they chip
Correct.
away physician power, physician income, physician autonomy, physician everything. And I
Yep.
think at the edge of that, right, you're seeing a healthcare system that is becoming less effective. It's becoming
Mm-hmm.
way less affordable.
Yeah.
And it's becoming the kind of place where you control less of your own future, whether you're a clinician or certainly as a patient. And
Absolutely.
I think doctors are coming to this in part because they recognize that unions are one of the most powerful forces to get a more affordable, effective, efficient, and safe healthcare system.
Yep.
Can you speak to the role that that's played in some of the ways that the demands that you guys push forward have been about protecting the healthcare system for patients writ large?
Yeah, man. You know, I want to go back to your last question just for a second and then tie it into the answer for this question, because I think it is really a continuation. So, not to be that white girl who quotes Martin Luther King, but like I grew up in Memphis, and growing up, every single year I went to the Lorraine Motel, which is where Martin Luther King was assassinated and is now just an incredible National Civil Rights Museum. And Dr. Martin Luther King was assassinated when he was in Memphis speaking to the sanitation workers who were on strike because two sanitation workers in Memphis had died tragically and gruesomely in a trash compactor. And during that speech, he says, and I'm going to paraphrase this, in terms of caring for our communities, the sanitation worker is as important as the physician. And that is 1000% true. And to your point about, the environmental or janitorial staff at the hospital, like they are as important as the physician, right? And taking care of that individual patient or all of the patients in that hospital. And, I think that we as physicians have to really find it within ourselves to interrogate why we don't just intuitively know that. Like we talk about, you know, sanitation systems, right, being so important in terms of curtailing the spread of disease, right? We talk about, the social determinants of health and, the impacts of our built environments of our, we talk about environmental impacts on health all of the time. So like we talk about that and then we don't understand or interrogate our role in those larger systems. And that is something that labor has understood for a really long time, like SEIU, 1189, National Nurses United, UHW, the list goes on, where other members of the healthcare, industry recognize that being part of the labor movement, yes, gives them a say in their own working conditions and their own salaries, but it also allows them to fight for the things that help keep our patients healthy or at least prevent them from getting sicker. And physicians, to your point, are really behind the game. And honestly, we should be embarrassed about that because it is our own internalized capitalism, our own elitism, our own perpetuation of these really inequitable, really exploitative systems, and our sense of superiority that has prevented us from engaging in these issues in a really meaningful way. And so physicians, like now, and honestly, it's just like so typical, but I think physicians now are getting to the point where we're like, wait, my research funding just got cut. Like, wait. I'm an attending who's been here for 20 years and you want me to see 3 extra patients through my lunch break? Hold on a second. Like, now that those things are reaching us on a personal level, we're like, oh no, this is unacceptable, right? And like, it is unacceptable. That's true. But all the rest of this shit is also unacceptable.
The power of unions is that they show you that your self-interest is tied to other people's well-being and their
Yeah,
well-being is tied to your self-interest. And
100%.
like, that's the thing about it, is that like, at the end of the day, if you look at your self-interest as being counterposed to the well-being of society, that's one way to
Mm-hmm.
look at things. And if you look at your self-interest as being tied to the well-being of society, that's another. But I think the reason, and what you're touching on, I think so eloquently here, is that for physicians, we've often sort of told ourselves this like half truth, which is,
Mm-hmm.
I'm someone who's here to help the broader public and to help my fellow man. And when you're pushed on that question and your financial well-being sits at the other side of the well-being of your patient, what do you do? And too
Yeah,
often, I think so much of our frustration, at least my frustration at the AMA, is that too often as an organization, it has sided on the wrong side of giving more people better healthcare for more affordable cost.
100%.
Um, and so it's like, okay, yes, you're just another doer of a particular service, and the worst thing
Mm-hmm.
about it is your service people literally die without. And
Mm-hmm.
so, I
Mm-hmm.
think the opportunity here is to rethink the way we organize so that our well-being as physicians is consistent with the well-being of the public. And look, I just want to be clear
Mm-hmm.
about something. It's important that people continue to feel incentivized to
Mm-hmm.
do the arduous work of becoming doctors.
Mm-hmm.
But the reason our healthcare system has gotten more expensive is not because doctor salaries have gone up. In fact, if anything,
No.
doctor salaries have gone down with time.
Yeah.
It's because huge corporations have been able to suck more of the value that's created in the healthcare system, or
Mm-hmm.
frankly, value that's exploited out of the healthcare system.
Mm-hmm.
And that comes at the cost of physicians. And what happens is,
Yeah.
in this game where doctors in general are losing,
Mm-hmm.
they've been able to play a few of us against the rest of us
Mm-hmm.
in ways that end up allowing most doctors to sort of think that this is all happening in our best interest.
Mm-hmm.
Even though over the last 20 years, like, there is no world in which doctors are better off, right?
Right.
And certainly we're being asked to do more
Yep.
for less,
Yep.
with less autonomy,
Yep.
and less, less of the joy of doing the work. And if you're sitting here thinking, I have 8 minutes with this patient and I at least need 20, and then
Mm-hmm.
I know that there are problems I could not solve for this person, that takes a moral toll.
Yeah.
And that's the cost of it. And
Yeah.
so, I just, this is the part that's really frustrated me often about doctors. Like, you guys want to have your cake and eat it too, right?
Yeah.
In one
Yeah.
case, if you're just like, listen, man, like, I work for a service, I happen to do this thing, and that's just fine. But like, I don't carry a moral authority because of what I do. Okay.
Yeah.
All right, fine.
Cool.
But to
Great.
sit here and say, yeah,
You're
like,
not my
I
labor
hold
leader.
this,
That's fine.
yeah, like, if to sit here and say I hold this moral authority because I'm one of the good guys who takes care of people when they're sick, then it's just like, okay, well, there's a second order question about how you're going to then engage in the world
Mm-hmm.
on the other side of that.
Yeah. Cool. Did you call your congressperson prior to this big bullshit bill passing? Because that's what actually showing up for your community means, right? And I think that, God, I like want to play back everything that you just said, like over and over and over for, the physicians who I'm meeting with constantly, because you're absolutely right. I think that, physicians are leaving the practice of medicine at a really unprecedented rate, and at this point, this is horrifying. The largest employer of physicians in the United States is United Healthcare. United Healthcare directly employs 10% of doctors in the United States. That is maddening. And I think you mentioned the AMA. I am not part of the AMA. I will not give them my money. But I learned something like last week that they are the 6th largest lobbying group in the United States. And they have a hugely problematic history, right? Of like advocating for continued racial discrimination, it's more or less single-handedly blocking a single-payer health system, right? Like just over and over and over, just
I mean, they
eroding.
opposed first initial Medicare
Right,
because it would desegregate hospitals. Like,
right.
that's wild. Like,
Monstrous. But like we aren't talking about that. And actually as medical students, they're like, okay, so you join the AMA and then you join, in my case, the American Academy of Family Physicians, and then you go to your meetings and then you do all these things and then like you follow professional guidelines and whatever. And like then you get your little gold star and then you've been a good doctor. And it's like we like that
and they
isn't
know we love gold stars.
working. I just want
Everybody
to
who goes
do
to
a
med
good
school
job.
loves all the gold stars.
Yes. And like I do want to do a good job. I really do. Like I mean, I really do want to do a good job, but I think what it means to do a good job these days has totally changed, right? Like, and like for physicians, I think the fact that the AMA is the sixth largest lobbying group in the United States, and our healthcare system, big bunny ears on the system, word system, is this embarrassingly bad is a problem. That's a red flag, right? And I think we are facing just horrifying attacks on healthcare, on science, on the middle class, right? And like at this point, I genuinely believe that physicians have a moral, ethical, and professional responsibility to fight back against this shit, right? Like if you are going to maintain this like sense of moral superiority and this like identity as someone who is pursuing a calling, right, which so many of us in medicine say, and I actually get that, like I can't imagine doing anything else, right? Then you have to get involved, like not necessarily in the AMA, but like in organizing, in the political process, in mutual aid networks, right? Like we have to. And if we don't, then we have to abdicate this throne of moral superiority.
Yeah. On that note, how can people get involved, Taylor?
Yeah, I mean, there will be, I can tease some exciting news about CIR and organizing attending physicians. And I think there may be some exciting news on the horizon there. So more to come with that. I would say physicians like start talking to your colleagues about what matters to them, like how they feel about Dr. Oz running CMS, how they feel about RFK running, HHS, like how they're feeling about practicing in this system, right? Just have these one-on-one conversations and just say, like, what's important to you? What doesn't feel good about how you're working? And start having those conversations with each other, right? And that's just like step one, right? Obviously, I'm going to say that is step one on a road to organizing in a union, right? Because I think unions are the single most effective tool that we have at fighting back against all this nonsense. But also you can organize without the structure of a union, right? Like you can look for mutual aid networks in your communities. You can call or send letters to your Congress people. You can get involved in your local politics, right? Like get involved in city council meetings, like, really just local issues. And then I think be willing to interrogate why you haven't done that yet, right? And get really curious about that and be honest with yourselves, right? Because
Yeah.
we have to shed these barriers, I think, that are preventing us from truly leading, right? Our colleagues and leading, like creating the change. What is it? Creating the change that we want to see in the world. Like we need to create the change that we want to see in the healthcare system in the United States, because we as physicians are uniquely positioned to do that, right? We have the expertise, we have the experience, we have the resources. It is now our time to use them.
Well, it's a privilege to be with you today, and we really appreciate you joining us. Our guest today was Dr. Taylor Walker. She's the national president of the Committee of Interns and Residents at the SEIU, which is the nation's largest physicians union, representing greater than 37,000 residents and fellows across the U.S. Taylor, thank you so much for taking the time. We really appreciate you.
Thank you so much, Abdul. This has been really fun.
That's it for today. You can find more content on our website, incisionmedia.co. Check out our shop at store.americadissected.com for our new America Dissected merch, including our logo shirts, hoodies, and mugs. And don't miss out on our Vaccines Work, Science Matters t-shirts. If you have guest recommendations for the show, send us an email at info@incisionmedia.co. You can follow or subscribe to America Dissected on your favorite podcast platform and on YouTube at America Dissected. And you can follow me on Instagram, TikTok, and X at Abdul no dash. And make sure to subscribe to Katelyn's incredible newsletter, Your Local Epidemiologist, which breaks down the latest scientific evidence for over 300,000 followers. You can search for Your Local Epidemiologist on Substack. Links to all our sponsors are available right here in the show notes. I really do hope you'll check them out and show them some love. They make the show possible every single week. Finally, on your way out, don't forget to leave us a 5-star review. And if you're watching on YouTube, drop us a like or a comment. Word of mouth still goes a long way too, so if you know someone who might like to keep up with everything that's happening in the world of health, please do let them know. America Dissected is a product of Incision Media. Our co-host is Dr. Katelyn Jetelina. Our producer is Andy Gardner-Bernstein. Video and audio editing by Nadine Melkonian. Our theme song is Wataka Suzawa and Alex Ugiera. Sales and marketing by Joel Fowler and Nick Freeman at Big Little Media. Our executive producers are Tara Knight and me, Dr. Abdul your host. Thanks for listening. This show is for general information and entertainment purposes only. It's not intended to provide specific healthcare or medical advice and should not be construed as providing healthcare or medical advice. Please consult your own physician with any questions related to your own health.